feel like we should have some hold music.
Be nice.
Right?
Some music. Well, good afternoon, everyone. Thanks so much for joining us. We appreciate your being here on the first day back to work after hopefully you had a long weekend and some rest. So today's clinical conversation is going to start now, and we are delighted to introduce our speaker and to just let you know about our topic. Just as a reminder, our clinical conversations program takes place on the fourth Tuesday of every month at 12:15. My name is Barry Sarvet. I'm the medical director for McPap. The topic is PTSD assessment and treatment guidelines for primary care. A couple housekeeping issues is that we will be recording the session, and the session is going to be available on the McPap website at www.mcpap.org, along with a copy of the slides, which is available under the newsletters and webinars page under About McPap. We're going to have plenty of time for questions, and so feel free to type questions into the question box during the presentation, and we will read out your question. Or if you prefer, you can just ask that your line be unmuted so you can ask the question yourself if that would be better for you. At the end, you'll receive a very brief survey following the presentation, and we really appreciate you taking a moment to fill that out so that we can use that for improving future presentations. I just want to also mention that today's topic is part of a series that we have, which is meant to be paired with our guidelines and clinical pearls documents that we have. As you may know, guidelines and clinical pearls, which are meant to be a reference and a resource for pediatricians to address learning needs for common presentations, common diagnostic groups. And so far we have a guideline on ADHD, a guideline on depression, a guideline on anxiety disorders, and also a guideline on OCD. And this is our fifth of these sessions, which is not specifically on PTSD or exclusively on PTSD, but really on traumatic stress and related disorders. And so our speaker will talk about that more in detail. And so now just about our speaker. We're very proud to have Dr. Sylvia Krinsky. She is one of our McPap child psychiatrists, and she actually is the site director for the Tufts team. She graduated from Case Western Reserve School of Medicine and did her psychiatric residency here in Boston at the Harvard Longwood Psychiatry Residency Training Program. She was chief resident of the DBT Partial Hospital Program at Mass Mental. She completed her Child and Adolescent Psychiatry Fellowship at Cambridge Health Alliance. She is a member of the faculty at Tufts in the Child Psychiatry Division, and she is an assistant professor of psychiatry at the Tufts University School of Medicine. Her special clinical interests include working with suicidal young people who have attachment and relational difficulties, many of whom have experienced trauma, and she has clinical expertise in DBT and trauma-informed psychotherapies. So with that, I'm going to pass it over to Dr. Krinsky, and she'll proceed with our presentation.
Thanks so much, Barry. So first off, starting with financial disclosures, I have no relevant financial disclosures and a few more disclosures and trigger warnings. This presentation will include some discussion of traumatic events, including sexual abuse and sexual violence. And I'm very opinionated and feel strongly that trauma has a broader psychological impact than is recognized in the DSM-5. And that is important because it's where I'm coming from in terms of my perspective on things. And many people interested in studying trauma feel the same way. And it's given birth to a lot of terms that are used commonly, but aren't quite in the DSM-5. And so we'll talk about that a little bit more as it comes up. The objectives of this presentation are to review the diagnostic criteria and differential diagnosis for PTSD and trauma and stress-related disorders, to discuss screening for adverse childhood events and symptoms of traumatic stress and how this occurs in primary care, and to then talk about our MCPAP algorithm for evaluating and managing traumatic stress disorders. And especially if there are questions about terminology or if there are main topic points that aren't clear from my explanations, I encourage you all to write into Barry on the chat function so that I can make sure everyone's following along, because some of this stuff can be pretty complicated and many people are starting with different levels of knowledge. And so if you have a question about what something means, my suspicion is many other of your colleagues do have the same question, and I would love to make things as clear as possible. So this is a definition of trauma that actually is the one that resonates with me the most, and it's from the Substance Abuse and Mental Health Service Administration. And they define trauma as an event, a series of events, or a set of circumstances that are experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And so that's really how I think about trauma and what trauma is. And there are different types of trauma. There's discrete trauma and complex trauma. Discrete trauma examples include car accidents, injuries, medical procedures, a single episode of abuse, of physical abuse or sexual assault, when life is otherwise filled with supportive and helpful people. And then there's complex trauma, which is a series of repeated traumas, usually in the context of close interpersonal relationships, such as childhood abuse or childhood neglect, or witnessing domestic violence or community violence. And adverse childhood event is another term that creeps in here. Adverse childhood event is a term from the ACE study, referring to potentially traumatic events that can have an impact on physical or psychological health. And so the difference between discrete trauma is more recognized in DSM-5 than complex trauma. And so people talk broadly about complex trauma, but if you're looking for where that word is, it's not a DSM-5 word. And adverse childhood events, I think many people are familiar with because of the ACEs study. So early childhood trauma has some differences between trauma that's experienced later in life. For example, when somebody's in their 20s. That early trauma between the ages of 0 and 3 can have a major and long-lasting impact on brain development. That if we think about all the brain changes that are happening between the ages of 0 and 3, there's so much cognitive development, motor development, and emotional development. And young children are entirely dependent on their caretakers. And so trauma that's occurring in the child-caregiver relationship has an effect on the attachment system. And so often we're thinking about things as biologic or psychological, but actually many things are biologic, that it's a little bit of a false dichotomy. And so our attachment strategies are actually biological systems that I think of my little axiom as people are like ducklings, and we imprint upon our caregivers. and we attach to them and connect to them and sort of follow them around. And attachment strategies have these different styles that are reproducible, and that trauma affects health, disrupts normal and secure attachment. And it has an effect on how brains develop, because little kids are learning so much through imagination and copying and mirroring other people. And so trauma in the child caregiver relationship at an early age really has a really long-lasting impact on the biological attachment system. And people have been looking at this and studying this too, and think about the attachment and attachment relationships as one potential mediator for why abuse and neglect in early childhood are linked with somatizing disorders later in life. So trauma is one of my areas of real clinical interest and passion. And as a child psychiatrist, I view it as really important. And there is a difference in my role as a child psychiatrist and your roles as pediatricians. And so for pediatricians, you guys are seeing kids and families, and trauma is coming on your radar in sort of two typical situations. One, immediately after a traumatic event, or two, in the assessment of mental health complaints. Or I guess lastly, in the series of a well child check, when you're checking in on how people are doing and they disclose that since they saw you last, a traumatic event had occurred. And so I wanted to start with thinking about a psychiatric differential diagnosis for in the context of after a traumatic event, something acutely has happened that is bringing the child and the family to your office to check in, because people said, follow up with your doctor. And they're sort of looking to you to get a sense of, in the wake of this thing that's happened, are there reactions and is their coping normal? And so just a brief differential of what to be thinking about in terms of how they might be reacting in the setting of an acute event is that they might be experiencing symptoms of an adjustment disorder, an acute stress disorder, PTSD. They could be having anxiety that's been exacerbated by a stressor, or they could be experiencing depression that's been exacerbated by a stressor. So I wanted to go through each of these categories of things to talk about both the similarities and the differences to help guide you in your assessment and formulation when evaluating a child and a family when they're presenting after an acute traumatic event. So first off is an adjustment disorder. And adjustment disorder is the most, is thought of as sort of like the most mild of the category of things. That adjustment disorder is not considered a mental illness. And what it's referring to is having difficulty coping and adjusting after a stressful thing. That the symptoms occur within 3 months of the onset of the stressor. They're not supposed to last for longer than 6 months of the stressor. And the distress is greater than what would be expected within the context and the nature of the stressor, and or by significant impairment in social, occupational, or other important areas of functioning. There's always exclusionary criteria in DSM stuff about if the difficulty is better described by another diagnosis, use that diagnosis word, and that it can't be due to an exacerbation of another mental disorder. And we're not talking about normal bereavement. So that's sort of what an adjustment disorder is. In terms of the diagnostic criteria for PTSD, because oftentimes, like again, we're talking about a kid presenting after an acute event. And so you're sort of thinking, is this, are they responding normally? Are they having difficulty adjusting? Are they developing acute stress disorder? Are they developing PTSD? Or do they have an underlying anxiety or depression that's exacerbated by this stress? So the first thing now that we're talking about is, what is PTSD? And so for PTSD, this is the DSM-5 criteria. For PTSD, there's been an exposure to a traumatic event. And part of how this is different than that SAMHSA definition that I'm talking about is what classifies as trauma. That for DSM-5 trauma, the list of things that count and qualify as that exposure to a traumatic event is really very narrow. That you're exposed to death, threatened death, actual or threatened serious injury, actual or threatened sexual violence. And you're exposed either by direct exposure, you're witnessing the event, you're learning that a friend or close relative has experienced the event, or you're exposed to indirectly to aversive details of the trauma, usually in the course of professional duties, like with collecting evidence or police who are reviewing or collecting statements from people or seeing photographic evidence of crimes that have been committed. And so that's what counts in DSM-5 for exposure to a traumatic event. So that's the first criteria that needs to happen for a diagnosis of PTSD. Then you have one of the following symptoms: intrusive thoughts or memories, nightmares, flashbacks, intense distress at reminders, or physiologic re-experiencing. And so that category of symptom is called re-experiencing symptoms. You have one avoidance symptom, meaning you're avoiding memories or thoughts about the trauma, or you're avoiding specific places or experiences associated with the trauma. Then the avoidance symptoms are the B criteria of PTSD. Then there's the and then there's the criteria of negative alterations in cognition or mood. And you need two of these for DSM-5 criteria, where you have inability to remember parts of the trauma, or negative beliefs about yourself or the world or others. You blame yourself for the trauma that's occurred, or there's a persistently negative emotional state, inability to experience positive emotions, diminished interest and participation in activities. And then there are these alterations in arousal and reactivity. You have two of these symptoms: irritable or angry outbursts, reckless self-destructive behavior, hypervigilance, high startle, concentration problems, and sleep difficulties. And this category of symptoms is often called and referred to as hyperarousal symptoms. So the difference between PTSD and acute stress is there's the same stressor criteria, the same symptom criteria, but acute stress, the symptoms have been present for less than a month. And in PTSD, the symptoms have been present for more than a month. Acute stress disorder symptoms are more common than PTSD symptoms. That oftentimes there's some group of people who have acute stress and then the symptoms remit. What I want to flag here is that PTSD symptoms lasting for more than 3 months are unlikely to remit without treatment. And so that's a specific group that we really, really should be encouraging to be seeking care and treatment for their PTSD, since they're unlikely to recover without treatment. So we've covered adjustment disorders as a differential diagnosis category. We've covered acute stress. We've covered post-traumatic stress disorder. Now there's anxiety disorders and depression. What if an acute stressor has occurred and it's actually exacerbating somebody's underlying depression and anxiety? And so one of the differences here, I sort of think about anxiety disorders as having an intrusive level of worry, frequently accompanied by somatic symptoms, including stomach aches and headaches, especially in younger kids, a misperception of situations as overly threatening or dangerous, and an urge to avoid that results in functional impairment. Oftentimes, when I'm seeing a kid for an evaluation of, is this kid traumatized by this life event, and it's actually due to an exacerbation of anxiety, the anxiety started before the bad thing happened, and oftentimes the amount of stress it took to dip this bad thing into a thing that's taking over the kid's life and family functioning, it's a smaller level stress. Sometimes I'll see kids that come in for an evaluation to present after the trauma of having a GI bug and they're not eating. And actually what's happening is that their anxiety disorder is flaring and they're having a vomit phobia and they're avoiding food. And so one thing that makes me think about underlying anxiety disorders is sort of like the level of the bad thing that happened. And it often, there's a lower threshold to cross before substantial psychological difficulty. Depression, and we're talking about anxiety as sort of a state of persistent worry. fear, nervousness, and being scared. Depression is a state of overwhelming sadness, hopelessness, difficulty enjoying things, a lot of ruminations, meaning worries and thinking that are about hopelessness and about guilt. There's difficulties with low energy, low interest, difficulties concentrating. There's changes in sleep, most characteristically early morning awakening, waking up at 4 or 5 in the morning before your alarm goes off, and typically a lowered appetite. Or psychomotor retardation is one of the other criteria for depression, and that's when all the movement is really slowed down. And suicidal thinking can be present in depression. So just hearing these things, we're looking at all the ways that the PTSD and acute stress disorder symptoms can overlap with depression and anxiety. That can make it a bit hard to tease apart. For example, are the intrusive thoughts or memories about the stressful thing that happened due to an anxiety disorder, or are they re-experiencing symptoms of PTSD? Are they avoiding memories or thoughts in specific places and experiences because of anxiety? Is this sort of anxious avoidance, or is it, the avoidance of PTSD? You can have negative beliefs about yourself, others, or the world, an inability to experience positive emotion, diminished interest and participation in activities. But doesn't that sound a lot like depression? And you can have alterations in arousal and reactivity, angry and irritable outbursts. Sometimes we see people who are more angry and irritable with depression, where you can have more hypervigilance, high startle, being more nervous and on edge, more difficulty sleeping, which we see with anxiety, where you can see concentration problems with PTSD, depression, and anxiety. So this seems very complicated and like a whole can of worms. The good news is that it's important. The good news is that it matters. There's a way that it matters and there's a way that it doesn't, because many similar treatment approaches are useful for all these overlapping symptoms. So when thinking about, is this depression, anxiety, PTSD, or all of the above, I think it's important for us to remember that trauma is a risk factor for many mental health disorders, and the presence of trauma can complicate treatments. But also pre-existing depression, anxiety, those are risk factors for developing traumatic stress after a traumatic event. I routinely use rating scales for depression, anxiety, acute stress, PTSD in my clinical practice. And I try to develop a coherent narrative of how a patient was doing before the traumatic event and how this changed afterwards. And this sort of helps me keeping in track of what symptoms and what rating scales are scaling the highest and are the most intense, and what is the time course. Helps me tease apart what, in my opinion, is the primary thing going on and what's secondary and a little bit in the background. Oftentimes when there's enough trauma, there's a little bit of everything, where the person meets criteria for an anxiety disorder, they meet criteria for a depressive disorder, and they also meet criteria for PTSD, and that's okay. And sometimes, and in the situations where you can get the most diagnostic clarity and narrow things down to a single disorder, is usually when there's like a single discrete trauma and a clear sense of what the baseline was and how the person was happening before the trauma, because the trauma is a discrete thing that happened only once, and so you can tease apart a before and after effect. Now, another thing to keep in mind is conditions. We talked about a differential diagnosis for mental health complaints after a stressful or traumatic experience. I also want to talk about this other circumstance where you as pediatricians are going to be evaluating a child because the child's having a mental health concern and you're building a comprehensive differential diagnosis. And in these cases, I think it's important to think about the role of trauma and PTSD, because PTSD can be misdiagnosed as autism, ADHD, or bipolar disorder. And part of how to tease apart, what I do clinically to tease these things apart is really about my history gathering. When I'm evaluating for mental health complaints, I'm always asking about the level of psychosocial stress a kid and a family are under, and if they've experienced traumatic events, because in order for PTSD to be present, there does need to be a traumatic event that happened. And I'm also getting a sense of what is the kid's developmental trajectory. So part of how I tease apart autism from PTSD is I'm really interested about the early developmental history and how the kid did in their developmental milestones. Sometimes PTSD presents looking like autism because somebody presents pretty withdrawn, a kid presents as withdrawn and pretty shut down, and their play can be pretty restrictive and repetitive. I'm interested in if their social skills change with people they know well. Because in kids with PTSD, when they have a secure relationship with other people, you can start to see more spontaneity and more social relatedness. Where in autism, I would expect somebody's degree of social relatedness to be more fixed regardless of the context. PTSD can be misdiagnosed as ADHD because they can both disrupt concentration. And so again, I'm interested in the time course of the symptoms, if a traumatic event was present, and if so, if so, is the kid's concentration worse after the traumatic event? PTSD can disrupt concentration because the kid is either preoccupied by re-experienced symptoms, or they're having trouble concentrating due to the hyperarousal, hypervigilance, increased startle, and difficulty settling. Also, PTSD can be misdiagnosed as bipolar disorder because of difficulties with irritability, anger, mood lability. So one thing that's important to remember about bipolar disorder is it's very rare before puberty. And in the cases of young people that are presenting with bipolar disorder in their early teens, or, or children that have a diagnosis of bipolar disorder, one of the things I'm really thinking about is family history, because I really expect there to be a pretty clear and compelling family history of bipolar disorder. So I wanted to present this as sort of ways of thinking about, could PTSD be part of your differential diagnosis for a kid that's presenting with behavioral problems or concentration difficulties? This leads us to our second objective. I want to discuss screening for adverse childhood events and symptoms of traumatic stress. So there are a lot of right ways of approaching screening, and what works for one practice can differ, screening and what works can differ by practice, and there's room for variation. I recommend screening for traumatic events as part of well-child checkups because it's a way of talking to people about difficult things outside of a moment of stress where maybe there's a little bit more time to focus on it. And I also recommend screening for traumatic events as part of the evaluation of mental health complaints and as sort of part of an ongoing psychiatric evaluation. I recommend starting with general questions about stress and stress the kid and family are under, and then moving towards more specific questions about traumatic events. So one might start by asking about, has anything stressful or scary happened? And then sort of starting to broaden it by asking about, based on what they're saying, yes, what are the sources of stress that you're under? Has anything happened that you think was upsetting or disturbing to your child? And then you can sort of move along that spectrum to asking about things has DCF ever been involved in your home? Has anyone ever hurt your child, or have you ever had concerns about your child being abused or hurt? Asking parents about what they're doing for discipline practices, asking kids about if anyone's ever, if they've ever witnessed fighting or, seen people being really mean to each other, or if they, if anyone's ever hit them or hurt them, asking if people touch their bodies in ways that make them uncomfortable. Those are some of the types of screening questions I ask to get a conversation going. I like a mix of clinical interviewing that really allows you to follow the narrative that patients are telling you, and a mix of rating scales so that nothing gets left out. And also with sensitive information, sometimes it's easier for people to disclose what's happening on a rating scale than having to say it face to face. So I like a mix between both. And I encourage everybody to start incorporating in rating scales that screen for stressful life events and traumatic stress when they're giving out packets of rating scales for well-child checks, and also when they're giving out rating scales like the SCARED or the GAD-7 or the PHQ-9, whatever you're using for rating scales for mental health-related complaints. This can sound like a lot, and sometimes if somebody's presenting with acute distress, you're really just trying to focus on what happened and how to stabilize the situation, and that is 100% okay. That your clinical priority is always about safety safety number one and the therapeutic relationship number two, so that they'll come back, they'll come back and rejoin, and you can continue things in an ongoing manner. So those are my priorities. And if stressful events have occurred or happened, I think it's important to check in about how the child and the family is functioning in the aftermath of this event. Assessing how upset and anxious the parent is, because the parent needs to be able to calm and soothe themselves to be able to calm and soothe the child. And to assess for degree of symptoms in the child, including if the kid is having regressed behaviors, difficulty separating from the parent, sleep problems, frequent tearfulness or tantrums, changes in play, withdrawal, hopelessness, or suicidal ideation. In adolescence, I think it's also really important to assess for self-injurious behavior like cutting and substance abuse, because those are commonly seen in the aftermath of traumatic events. And it's important to assess the availability of the parent or adult to provide support to the younger person. Having a supportive person in your life that you feel cares about you and understands you is a really, really protective factor. So in terms of rating scales, my personal favorite rating scale for screening for stressful traumatic events and kind of adverse childhood experience, and then the symptoms of post-traumatic stress disorder, is the CATS, the Child and Adolescent Trauma Screen. It's a free measure. It comes as a caregiver report for younger children. I think it's up to 6. And then there's a caregiver version for ages 7 to 17. And there's a self-report version for kids for ages 7 to 17. Sometimes, and I think of this as a way of augmenting my clinical interviewing, so that let my checklists sound like checklists, so my interview doesn't have to sound like a checklist. So the trauma screen is screening for potentially traumatic events, natural disasters, serious injuries, physical abuse, abuse at school or bullying, physical assault, witnessing domestic violence, witnessing community violence, starting to screen for sexual abuse, online bullying, people being mean, traumatic losses, including sudden deaths or violent deaths, stressful or scary medical procedures, which I think sometimes get overlooked because we like to be seen as helpers, and that medicine is helpful, and that's true, but also certain medical procedures can be scary and leave a traumatic impact. Being around war is an adverse event and stressful scenario, or anything else that they note. And I like that flexibility in screening, but also allowing them to put what's on their mind. And if they said yes to one of those things, then they turn the page and they get to this rating scale, and they answered about all the scary or stressful events that happened to them. It asks about symptoms in the past 2 weeks, and it's scaled never, once in a while, half the time, or almost and always. And then this sort of a screening for along the DSM criteria for re-experiencing symptoms, avoidance symptoms, negative alterations in cognition, and hyperarousal symptoms. The screen that I've put up is from the youth report for ages 7 to 17. And I wanted to share it because it gives a way of some ways of asking about these, the post-traumatic symptoms. If there's upsetting thoughts or pictures about what happened that pop into your head, that's screening for those intrusive thoughts and memories. Bad dreams reminding you about what happened, it's nightmares. Feeling as if what happened is happening all over again, that's screening for flashbacks. Feeling very upset when you're reminded about, that's logical arousal when you're exposed to something that reminds you of the event. Having strong feelings in your body when you're reminded of what happened. Sweating, heartbeat, fast stomach, upset. So those are screening for the re-experiencing symptoms. Questions 6 and 7 are screening for the avoidance symptoms of traumatic stress. Trying not to think about or talk about what happened, or not to have feelings about it. Staying away from people, places, things, or situations that remind you of what happened. Those are avoidance symptoms. Questions 8 through 14 are about what's called the negative alterations in cognition, not being able to remember part of what happened, negative thoughts about yourself or others, thoughts like I won't have a good life, no one can be trusted, the world is unsafe, blaming yourself for what happened or blaming someone else when it isn't their fault, bad feelings, feeling afraid, angry, guilty, ashamed a lot of the time, not wanting to do the things you used to do, not feeling close to people, not being able to have good or happy feelings. And again, as we listen to those statements, you can sort of hear the overlap with depressed thinking and also a little bit with anxiety. So 15 to 20 are screening for the hyperarousal symptoms, feeling mad, having fits of anger or taking it out on others, doing unsafe things, being overly careful or on guard, being jumpy, problems paying attention or trouble falling or staying asleep. And again, those symptoms can overlap with anxiety. So when you use this form, you can total up the score, and it can start helping you towards a provisional diagnosis of PTSD, especially if they're screening, if they're more than 21, it's probable PTSD. For if the score is 15 to 20, they're in moderate trauma-related distress. And if the score is less than 15, these ratings aren't clinically indicated. And the functional, and then the mark yes or no if the problem's interfered with, it goes along with that functional impairment criteria. So you can be using this form to support your diagnosis of PTSD or acute stress disorder. The difference between PTSD and acute stress being on, are the symptoms present for more than 4 weeks? And then, and if they meet criteria in each of those symptom domains. I also like the CATS because there's a symptom progress monitoring form asking that you can give on follow-up visits. Having a score of more than 4 is clinically significant. And it's just an abbreviated 6-question form that's pretty easy and short to complete. So that's one of the reasons that I really like the CATS and why I'm recommending it as a way of screening for traumatic events and also for symptoms of traumatic stress. There are many other rating scales, and if you already have a system in place in your practice, that's totally cool. I just wanted to share the one that I'm currently finding the most helpful. So in terms of when we've elicited that a traumatic or stressful event has occurred, it can often create a lot of anxiety in the provider who wants to be helpful and feels anxious and nervous about how to respond to this event. The most important thing is to stay calm and to use validation and empathy to create an atmosphere of safety. There's often a concern that asking questions about what happened or trying to understand what happened might re-traumatize somebody. And so just getting a general sense of the type of category the traumatic event falls in will not cause PTSD or complicate their treatment or anything like that. Sometimes there's this idea out of like debriefing in the aftermath of an acute stress has been linked with with more likelihood of developing traumatic stress symptoms later. I think in kids that's a little bit unclear because there was a reassuring study about that. But that's really about debriefing of walk me through exactly what happened. Just getting a sense of the type of thing that happened and how everyone's coping in the aftermath will not traumatize people. If a parent starts telling you about something and is going into graphic detail, especially about something like domestic violence in front of the child, I recommend setting a time to talk with them separately to just sort of divide it up. And, I think in assessing for traumatic events that are happening, we're always assessing safety in the present moment. Does anything need to be reported to DCF? Like, is anything fileable? And meeting criteria for 51A. And then I think also thinking about screening for suicide risk. I really like the CATS form, but one thing that is missing from it is it's not asking parents and kids directly about if there's hopelessness and suicide. It's not asking directly if kids are experiencing suicidal thinking. And so that's something that's also part of my safety assessment. And if that's present, oftentimes that requires a higher level of care. If there's an acute risk, like an ER or a mobile crisis eval. Sometimes there's a question about sexual abuse in a young child, and like a parent will have a wish that our interview can confirm this. I want to help support everybody in feeling like actually you don't need to get involved in that, that is the purview of a forensic evaluation through a child advocacy center. In my experience, when I've referred kids to a child advocacy center, I've had to file a 51A first. That happens very rarely, but I want to throw that out there because one of the concerns about interviewing is that if people are trying to figure out for like legal reasons what happened, it's good to not tamper with the interview and really send that to an expert from the start. Okay. Barry, any questions on the chat function?
No, not at the moment. I think you should feel free to go right ahead, Sylvie.
Awesome.
Yeah.
Awesome. So, okay. So I do want to talk about the algorithm for evaluating and managing traumatic stress disorders. So the way our algorithm is laid out is that it starts with a screening question. Has anything really scary or upsetting ever happened to your child or anyone else in your family? And I think that's a great question to ask during a routine well child check, and also to start a conversation as part of a mental health evaluation. For the kids ages 7 to 17, I think that they can be asked directly the question, has anything really scary or upsetting happened to you or your family? And based on what they're saying, you can expand your interviewing, gather details, assess for any kinds of imminent safety concerns, whether something happened that needs to be filed on, or whether or not if there's a concern about suicide or harm to others, that's ER crisis eval. And in the course of interviewing, if it seems like there's enough going on that it would be useful to have the cats, I would be putting the cats in and recommending getting screening with that, because it's a way to get a more quantitative measure of the symptoms in addition to clinical interviewing. And then based on those different score ranges that we discussed, we can break the symptoms down into probable PTSD, moderate trauma-related stress, and that there's normal functioning. And so for the kids where something traumatic has happened, there's no acute emergency, you don't need to file on anything, they don't need to go in the emergency room. You want to be providing support and empathy, building a relationship and rapport with the patient and the family, and encouraging healthy coping. And what I mean by that is encouraging parent-child quality time, because that connection and relationship is a protective factor. Helping them with making sure they have good sleep hygiene, bedtime routines and rituals, and self-soothing skills, including deep breathing and progressive muscle relaxation. So those are, and also sometimes talking about how some amount of regression after a stressful event is normative. For the people with moderate trauma-related distress, I recommend also using screening for depression and anxiety. And, if they're screening positive on the depression and anxiety, you can treat according to the MCPAP algorithm. That the presence of PTSD doesn't mean that their anxiety and depression cannot be treated if clinically significant, just means their presentation is more complicated by the presence of a trauma. You want to monitor closely for suicidal ideation and self-injurious behavior. And if they're scoring in moderate trauma-related distress, you're considering referring for trauma-focused therapy based on the availability of the resource and the parent and family preference. You're providing education on trauma and encouraging healthy coping, and scheduling a follow-up visit in 4 to 6 weeks to ensure the symptoms are resolving.
Hey, Sylvie. We did have a question just a moment ago about screening for patients who are 18 or older. Do you have any recommendations about that?
Yeah, that's a great question. Thank you so much. So for patients who are 18 and older, I recommend using a PCL5, which is very similar. The PCL5 is very, 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 very similar to the questions, the symptom questions on the CAT 7 to 17. And I think that I don't know about so I use that for my symptom measure. I might still be giving the same adverse event measure to people who are 18 because I find it a useful way of screening for scary and traumatic things, and the form doesn't take very long to fill out. And I still want to know if those things happen regardless or not of their age. So for the people who are scoring in the probable PTSD range, you can again be using the depression and anxiety algorithms for MCPAP. and again, monitoring for suicidal and self-injurious behavior. I'm strongly recommending a referral for psychotherapy, especially if their symptoms have been present for more than 3 months, because remember, those symptoms are unlikely to remit on their own. And if they're scoring in the probable PTSD and they're in pretty profound distress, I might be thinking about using a medication, which I'll talk about in a little bit more detail. Conveying hope for recovery. And I would recommend scheduling a follow-up visit in 4 to 6 weeks to ensure a connection to specialty care. And if wait lists are long, making sure they're not getting worse. Just very briefly about evidence-based trauma therapies. Trauma-focused CBT is evidence-based psychotherapy for trauma. Evidence-based psychotherapies for trauma are the first-line treatment. And so trauma-focused CBT is evidence-based trauma treatment. There are also child-parent psychotherapy and parent-child interaction therapy are also evidence-based treatments for trauma, and they have a little bit of an emphasis on restoring the parent-child relationship. ARC has an evidence base in the treatment of trauma, and it's one of my favorite trauma modalities. And the National Child Traumatic Stress Network, the link that's there, has a really good resource explaining these different forms of trauma therapy and has wonderful handouts for patients and parents. Just very briefly about trauma therapy. Most of the evidence-based trauma therapies focus on relaxation and self-soothing skills, restoring healthy relationships, and making sense of the traumatic thing that happened in a way that both acknowledges how terrible it was without making it anybody's fault and allows for some hope and room for recovery in the future. I think about when to consider medication. When a patient has comorbid depression or anxiety, meaning you give them a PHQ-9 and a GAD-7 and it's like a million, I would be thinking about using an SSRI according to the MCPAP depression and anxiety algorithm. If their symptoms are causing significant distress or functional impairment, despite an adequate trial of an evidence-based therapy for PTSD, I'm thinking about medicine. If somebody's been seeing a wonderful trauma therapist and they've been seeing them for a few months and they're still really suffering and like not doing well, I think about trying to see if I can augment the therapy with some medicine. Or if this is somebody whose symptoms are so severe, it's limiting their engagement in the first-line treatment, then I'm thinking about using a medicine. All the medication treatments for PTSD in children and adolescents are off-label, and nothing is FDA approved, so that should be part of the informed consent. And how I think about medications is really in response to symptom clusters, where for sleep difficulties, I'm thinking about a trial of, and I'm thinking about what symptoms causing the most functional impairment. If I had a magic wand and I could help you with one of these symptoms, which would it be? If I had a magic pill that could take away one of the things that you're experiencing, what category of thing would it be in? So for sleep difficulties, I'm thinking about trying melatonin first, because why not? And then if melatonin isn't useful, I'm often going to clonidine. For severe nightmares, sometimes I'm thinking about prazosin. The older the kid, the more comfortable I'm using prazosin, because prazosin does have the FDA labeling, I think. In people who are over 18, it is like a recommended standard treatment for PTSD nightmares in adults. The younger the kid, the more I'm sort of torn between prazosin and clonidine. And this is a complicated situation, which I would encourage you guys to be calling to discuss with the MCPAP child psychiatrist on call. Clonidine, guanfacine, and prazosin are all alpha agonists, so they really shouldn't all be mixed together due to the risk of hypotension. And for hyperarousal symptoms, which are those symptoms of feeling mad, doing unsafe things, being overly on guard, checking for who's around you, being jumpy, problems paying attention, and sleep difficulties, I often recommend a trial of an alpha agonist. Let's see. For the negative alterations in cognition, I'm thinking about an SSRI trial, which I also think makes sense given the overlap with those symptoms with depression and anxiety. And the dosing of the SSRI is similar to in the anxiety and depression algorithm. The only thing I would say when treating somebody who has a trauma history and there's PTSD in addition to the depression and the anxiety is I'm more cautious in my follow-up. I'm screening more for safety issues because they're running in a higher risk cohort. And I find that the medicine is really only partially effective. That oftentimes, even when I've reached an optimal dose of medicine, there's still clinically significant symptoms that need to be targeted with an evidence-based psychotherapy. And so I'm setting an expectation that the medicine is useful in augmenting therapy, but the medicine alone isn't going to really be sufficient. If somebody is really doing great for 6 months to a year in treatment, I do think it's worth thinking about if they can taper off the medicine. The more complicated and ongoing the stressors, the less I've had this be the case. But I think it's worth thinking about, especially in cases where there's a discrete event or a discrete stressor. Oftentimes one of the challenges for people who have experienced stressful events and relational traumas is that some of the dynamics of trauma about being forced to do things you don't want to do comes up with people's interactions with the healthcare system and can complicate the process of transfer and care or following up to see a different person. So I would encourage you all, if that is happening, where you're in the situation where you have evidence-based trauma-informed psychotherapy available, you've made the referral and your patient's, the family's not following up, the first step is to understand their point of view and use your motivational interviewing techniques to elicit the barriers to engaging with the mental health care system. Sometimes there's a wish that somebody else will just fix it and it wasn't going to take effort on their behalf. And that's valid as a wish. And I say that would be great. And I highlight my own limitations. And that's sort of a rare part of the time. Most of the time there's sort of anxiety about what it means to see a mental health care professional. I also emphasize the need for parental involvement in treatment. And the younger the kid, the more I really feel like the parents need to be involved in the therapy and in the treatment. And techniques that I've used to help support people in following up is like doing things as simple as during a follow-up appointment with you, they'll follow up with you, they're not scared of you, they know you, they like you. You've cured many ear infections and reassured them effectively when the child has had many colds. So they'll see you, but they don't want to see an outsider. Is even in that time making a phone call, returning a phone call about their referral in the office together, or saying, well, you know, if they don't want to call together today, saying, well, I want you to come back in 4 weeks. And if you haven't called at that time, let's call together. And that's just a simple way of building some accountability around the referral. More often, they can't follow up because of the access to resources. And so, you know, it's not uncommon as CAP on call to get a call of you've placed referrals for specialty care. You've recognized that there's trauma. The kid and the family are very distressed and you're not sure what to do or how to help. And it's sort of this feeling of this kid needed outpatient treatment 4 months ago. And oftentimes in those situations, this kid needed treatment 4 months ago, tell me the smart thing to say or the medicine that's going to fix it tomorrow. And when there's that kind of press or energy around the call, I'm often thinking, are there acute safety concerns? Because that's part of this, the anxiety around this needs to be solved like yesterday. And if there's acute safety concerns, again, mobile crisis eval or ER evaluation. If the symptoms are functionally impairing, the kid's not leaving their room, not leaving the house, but there's no acute safety concerns, actually that kid probably requires a partial hospital level of care. And if there's severe symptoms limiting functioning, including school refusal, and the family's unable to manage at home, that might require a higher level of care like a CBAT or an inpatient admission. Oftentimes, in order to achieve that level of care, it requires an emergency room eval or mobile crisis eval. So when there's that kind of press of this needed to be fixed 4 months ago, what can we do? I need you to guarantee it's going to work without causing any adverse effects. What can I say or what medicine can I prescribe? Actually, the answer is usually in assessing the level of care. And really what they need is a higher level of care than outpatient care. These are just some resources for you guys very briefly. There's 2 interviews on YouTube. That's a sample parent interview talking about ACE events and a sample child interview. I think these are actors. It's like for education. And so if you're feeling like you want a little bit more detail on how to interview a parent and a child going through the trauma screen and talking about trauma, those are 2 resources. SAMHSA has wonderful handouts and infographics on trauma, and I really like that handout. And it's one thing I will be using now as part of my psychoeducation about trauma. MCPAP, we are working on updating our webpage, and we have information for you about trauma. The care process model for pediatric traumatic stress via the Intermountain Healthcare public webpage has a wonderful, very comprehensive document about assessing and screening trauma in primary care. And so I encourage people to check that out. And the National Child Traumatic Stress Network is a wonderful website with lots of resources for kids and parents. So with that being said, I have left exactly 5 minutes for questions.
Sylvie, thank you so much. That was a really, really nice presentation. And I would just add one kind of comment about the algorithm is that that some of the slides had screenshots of our algorithm, and the slides are available. They will be available shortly after the presentation on the website, as I said before. But the actual final version of the algorithm should be available within the next few days. That we're just doing some last minute formatting work on it. But I think a lot of the references to the guidelines kind of will be helpful when you actually have the guidelines in your hands, and so you'll have them available just in a few days. It looks like we have one question that popped in. Oh, there's from Dr. Chang. Ruby Chang asked how they can get copies of the CATS questionnaire.
Yeah, well, I guess one of my hopes would be as we update the as we update the MCPAP PTSD webpage, that we could have the CATS on the webpage. Do you think that's something that we'd be able to do?
Oh yeah. In the meantime,
I just Google it, CATS ages 7 to 17, and I just click on the PDF that comes up.
Yeah, it's readily available out there on the interwebs.
That's how I found it on Google. That's how I found it, and it became my favorite form. Is I Googled PTSD rating scales.
The easiest way is to Google CATS trauma, because there's probably other CATS acronyms, and also put PDF in the search box, and that'll probably hit you, bring you to the top on the list. Will be the actual tool. So that looks like another question has come in. Oh, that was just Dr. Chang thanking you for the answer to that question.
Thank you for such a lovely answerable question.
So we have a few more minutes, so feel free to type a quick question in the box. There's still time. We'll wait a couple more minutes.
I guess I'm hoping this means that it was clear. It's a complicated and confusing topic.
Mm. Looks like all is quiet on the Q&A board at the moment. So I guess we can give people the gift of 3 minutes of time before you have to go on to your next thing. But I want to just thank Dr. Krinsky again for her excellent presentation. And then we will be distributing the PDF versions of the guidelines. And I think that we're actually going to distribute the CATS as well, along with the updated guidelines and the clinical pearls documents.
We should do that, as well as that little follow-up form, because it's great.
Yeah. So the CATS and the follow-up CATS, I think we'll plan to do that. All right. Well, thank you again for joining us, and we'll see everybody back hopefully in June. I believe that that we have one coming up in June. We will be in touch with you. Sometimes we take a little break over the summer in July and August, but I think that we have a presentation on deck in June, and we will communicate with you about that. But thanks again for joining, and thanks to Dr. Krinsky for the excellent presentation.
Thanks for having me.